It's a great honor and pleasure to host Professor Francisco Carnevale, a pioneer in prostate artery embolization, who will present the PAE challenges and also share his feedback and insights into building a PAE practice. After Professor Carnevale's presentation, we will have a demonstration of a new product which is 510K pending, called Embo Assist with virtual injections. So please stay till the end to be able to see the demonstration. Over to you, Professor Carnevale.
Okay, thanks much for GE for inviting me for this amazing project that we have started 3 years ago in collaboration with GE and also at the University of São Paulo Medical School. This project started because, as you may know, our team is recognized as the pioneer team in prostate artery embolization for BPH. So here I will bring a background on the disease and to say that BPH, benign prostatic hyperplasia, is a high prevalent disease. About every man during the life will have BPH if we analyze the prostate tissue. So histopathological findings show that every man will have it. However, if we consider clinical symptoms, we can say that after 60s, 70s, every man, or 30% of these men will have at least one symptom that will need to be treated. So it is high prevalence, and also what we can see is the consequences of this high prevalence disease. You can see the numbers of obstetric visits, also the emergency visits in the hospital here in the United States, number of hospitalizations, and the labor loss, and the huge $4 billion annual cost for the United States. So it is totally related to the symptoms that all these patients can present during their ages. And also we can identify here the most common symptoms as frequency, urgency, nocturia, urinary incontinence, and also urinary obstruction. So as you can see, all these symptoms, they should be managed. And also what we start to identify is when a patient come to urologists and say that their urinary flow is not as good as it was mostly before the 50s. So here you can understand their normal flow and the flat curve when these patients have prostate enlargement, mostly due to BPH. So here you also can understand using imaging, that is our focus, with ultrasound and MRI. You can see that using ultrasound, you can evaluate the intraprostatic protrusion. Also, you can identify using an MRI, you can identify the BPH nodules, the size of the prostate, the percentage of the transitional zone, the central gland of the prostate, and also the peripheral zone where we usually have prostate cancer. And also you can identify when patients wait so long to be treated, to be managed with medication or surgeries, they had some complications like stones or diverticulum, as you can see here. So that's why all these patients, they should be managed. And the first way to manage these patients is behavior. Sometimes we tell our patients to stop getting liquids during the afternoon and nights. And we also should start giving medications. And there are two main groups of medications. Alpha blockers that reduces the consistency of the gland, make it smoother. And also there is another group that reduces the size of the prostate. There is 5-alpha reductase. So all these groups of medications, they are efficient. However, there are some adverse events that we should keep in mind. And also there are another option, that is the surgical treatment. Surgical treatment for patients that don't want to face the risk and patients that have some complications that don't get the medication accordingly. So they could move to surgical treatments. And when we talk about treatments, we usually have two main groups of treatments: the endoscopic treatment and the open prostatectomy. Usually open prostatectomy is recommended for patients with prostate over 80 grams, 100 grams. Also, whole lap laser can be used for these big prostates. But most of these treatments for smaller prostates, and smaller means below 80 grams, can do endoscopically. Endoscopically means you can use TURP, transurethral resection of the prostate, and also laser, like ring laser. So these two groups of treatments, they are very good, very efficient. However, there are some complications like retrograde ejaculation, urinary incontinences, and some patients can have bleedings and impotence. So every patient needs to be aware about that, and physicians need to be aware to say and choose what is the best treatment for these patients. So we, interventional radiologists, we have used embolization. Embolization means to occlude a vessel, to block the blood supply for an organ or structure. And the rationale for that, using in prostate artery embolization, specifically for BPH, is that BPH is a hypervascular condition. This hypervascular condition, this disease can be embolized, blocking the blood supply, getting ischemia in the prostate. And what happens when we block the blood supply in the prostate? We can reduce the prostate size. We also can change the tissue, getting a smoother tissue because of a coagulative necrosis that we can get into the prostate, specifically in the transitional zone. And also we are able to block the hormone action, and as a consequence of everything is an erythral decompression, changing, reducing the prostate consistency and controlling the disease progression. It is very important because we can have the same effect of medications, and as a result is improving quality of life, symptoms, and urinary flow. Here I will present a video that will show when patients void. So here we have the normal emptying of the bladder. We have the bladder, the prostate immediately below, and the urethra. Here you see that urine, when you void, passes through the urethra channel, and we see that we have the prostate immediately below. And what happens when we have the enlargement of the prostate, we get a stricture, specifically in that region immediately below, where we have the prostate. The urethra get a stenosis. Embolization, prostate artery embolization, is a minimally invasive procedure done under local anesthesia, outpatient basis, where we place a 5-French catheter. You can talk to the patient during the procedure. You navigate with your catheter and microcatheter until you get very close to the prostate. You get cone beam CT to identify all the structures, the vessels, and you start to inject microspheres, any kind of particles blocking the blood supply, getting reduction in the prostate, changing the tissue, and you alleviate the obstruction, the stricture that it was caused by BPH. So here, during the last 10 years, when we start to do this procedure, we start in 2008 at University of São Paulo Medical School, we identified several problems and things that we should challenge during the procedure. So the most common challenge to do these procedures, the first one is the identification of the prostatic arteries. So sometimes we have one prostatic artery. Other times there are patients with 2 or more prostatic arteries that should be catheterized, should be identified, catheterized, and explored with digital images. The other thing is the catheterization, and understand where we should place the microcatheter when we are doing the procedure. And another thing is to understand the region that artery that we have catheterized is feeding. If it is feeding the central gland, if it is feeding the peripheral zone, if it is if we have some branches going to the median lobe, to the apex of the prostate. So it's really very important to understand that. The only way to understand is using cone beam CT. There is a very useful tool for this procedure, and it will give us a better vascular and prostate anatomy understanding when you use cone beam CT with less radiation dose, less contrast medium, and a faster procedure. We will avoid non-target embolization. You may know that this region around the prostate, we have connections with bladder, seminal vesicle, rectum, and also penis. So we must avoid all these organs, all these communications to get a safer procedure and a better long-term results. So with cone beam CT, we have a safety and efficacy. It is really proved. And what are the best candidates for these procedures that we have observed in the last 10 years? We can offer this procedure for elderly and also for young patients. Elderly, mostly patients with comorbidities, diabetes, smokers, and other disease. Youngers, mostly patients that don't want to face the risk of retrograde ejaculation related to medications or surgeries. Also, patients that have mostly moderate and severe symptoms. Patients also with indwelling catheters, the end stage of the disease with acute urinary retention. Patients that don't want to face the risk of medications, and also patients that don't want to face the risks of surgical procedures, like, again, retrograde ejaculation, urinary incontinence, and patients with coagulopathy. We have studied and observed and published last year that as big as the prostate is, better results we'll have. We should treat patients with prostates over 30 grams. And also, we should measure the percentage of the central gland that we have in the prostate. The transitional zone is really very important because we know that BPH is in that region. So we should understand, evaluate, analyze the percentage that we have in the transitional zone. And we have observed that above 45% of central gland are the patients that are the best candidates with less recurrence rate during long-term follow-up. And the main benefits of this procedure are: it is a minimally invasive procedure, is done under local anesthesia and as outpatient basis, performed for any size of the prostate. We can treat patients with 300 grams, 400 gram prostate, 100 gram, whatever. They should be above 30 grams. Performed in patients with comorbidities, severe comorbidities, and under anticoagulants and antiplatelets. That could be a complication for traditional surgeries due to bleedings. We will stop giving medications to these patients, avoid complications. There is no penile manipulation, no urethral manipulation, without retrograde ejaculation, no erectile dysfunction, and also no urinary incontinence. So I would say that all these patients should be evaluated by a neurologist. It's really necessary to work in collaboration with a neurological team. Interventional radiologists, and neurologists, they should work in collaboration to offer prostate artery embolization as a new alternative of treatment that we will decide together. And right now, we'll have the discussion with my friend.
Thank you. I have my mic already. Good afternoon, everyone. I'm going to present you Embo Assist. So I would like you to come closer because I'm going to do a demonstration on the screen. Don't be afraid by the cameras. You can step in the same line. Please come closer. Right. So before starting, I would like to inform you that Embo Assist is currently 510(k) pending at the FDA, and so not commercially available in the US, and it's not CE marked. We are talking here about prostate artery embolization. This is a procedure which is complex because the vasculature is complex. So it's very important to perform cone beam CT. And thanks to our IGS technology with a whiteboard, we can accommodate easily cone beam CT even on obese patient with the arms down. As well, with a unique OF offset C-arm that we are proposing, we can image down to the pelvic area over a course of 200 degrees on a 5-second spin without compromising the reconstruction of a high-definition cone beam CT. So once you have your cone beam CT, it's about the planning. So Embo Assist has been designed for the general purpose of embolizations, and it's well tailored for procedures where cone beam CT is important to analyze and understand the 3D vasculature. So I'm going here to show you a demonstration of Embo Assist. I will take as an input cone beam CT that has been acquired at the level of the internal iliac, and I will launch this information on the Embo Assist software. So as you can see here on this environment, you can leverage the detailed information from the cone beam CT. As you can see here, the fine vessels at the level of the prostate gland. And with one single click, I will be able to automatically extract the overall vasculature. This segmentation can then be used for the analysis. Professor Carnevale, can you tell us, based on your experience, why it's important to depict all prostatic branches for this procedure?
As you can see here, there are several branches in the pelvis that could be fitting the prostate. So it is really important to understand which is and how many branches are fitting the prostate. And with the software, you will see that you can use the axial view, coronal and sagittal view, to identify any branch that could be fitting the prostate. And you will work and achieve only the branch that are fitting the prostate.
So what I will do now is to activate a unique tool that is called the virtual injection. And if you look at this screen here, you will see that based on the location of my cursor, the software will automatically and dynamically simulate from any point what is the proximal path in red, but as well all distal vessels from that point. So when you are used to prostate artery embolization, you can recognize vessel patterns that may be interesting for selecting an artery. Let's say this artery looks interesting and probably one of the prostatic branch. You can verify in the cross sections the distal vessels. This is what I will show you here on this axial view. You can see in green here what are the vessels beyond that point. And you see that a large part of the prostate gland is fed from that vessel. So this vessel is interesting, and I will save it as a model with one click. That will appear here. But if we look further in detail, you will see as well on the cross-section that we are missing some branches in the posterior part of the prostate. So we can activate again this tool and check what is the origin of this vessel, for instance. And then we can go more proximally and verify that there is an additional potential artery here that is feeding the prostate. So we can save this model. A new model will be created. And now it's not only about selecting vessels. It's as well, where am I going to inject my drug? Am I going to inject to treat this vessel and then this vessel? Or is there another alternative? Maybe the bifurcation will be a good opportunity to treat from one point. So I can activate again here and define a point at the origin of the two vessels. You can verify here on the cross sections that the entire prostate is covered and that there is no extra prostatic branches going outside of the prostate. So this point is interesting here to be defined for the paling purpose. And then we will be able to leverage this information as an overlay on the fluoroscopic images using Vessel Assist. Professor Carnevale, you are today equipped with Vessel Assist. Can you tell us what is your experience with this tool?
I can tell you the experience for the last 10 years that when we start to do that, in the past, when we identified all these two branches, specifically the orange branch, the posterolateral, the capsular branch, we didn't embolize this branch because we thought, first of all, we didn't recognize as a prostatic branch. We thought it was a rectal branch. And we know that the rectal, sometimes it has connections with the capsular branch. And the only way to identify is use cone-beam CT. In the past, we were treating only the blue artery because it's the artery that is going to the central gland, the transitional zone of the prostate. We get good results? Yes, we can get, and we got good results. However, recurrence is totally related to that orange branch because we can get revascularization from the inferior portion of the prostate through the capsular branch. So as you can see, there are some connections between the blue and the rosin, that is the orange, and that is the capsular and the central gland, and revascularization occurs. So if we need better long-term results, it is really necessary to embolize both branches.
So here on that screen, I'm simulating what you would observe using Vessel Assist. You can work in the large field of view, collimate, and then use the digital zoom functions to work in a more comfortable situation. And you will have, based on the table position and the gantry orientation, the overlay of the planning over the fluoroscopic images. You can use several models, the anterior branch, the posterior branch, or the two models at the same time. And now, once you have reached that point with your catheter, it's important to control what will be the effect of your embolization. So, Professor Carnevale, you did initiate this technique of selective cone-beam CT for the prostate artery embolization. Can you tell us why is it so important?
That's the time that we should use cone-beam CT to identify the percentage of the prostate that we have covered with this artery. We can identify end branches fitting the median lobe, the apex, and the transitional zone. So with that, you will really understand what you are doing, and mostly, and more important, where you are injecting your particles. Because the aim of this procedure is to inject the particles to get ischemia in the prostate. If you have any connection with the bladder, rectum, or penis, or pineal artery, you get a complications due to the particles injection. So it is really important to get this information and do a safer procedure.
So what I did here is that I loaded the selective cone-beam CT that has been acquired from that point. And I had as well added the simulation coming from the planning. And you see here the great match that we have between the virtual injection from the planning and the selective cone-beam CT that has been acquired from the same place. And we can confirm here that there is no extra prostatic branches. So during this demonstration, you saw how we can leverage cone-beam CT acquired on our IGS platforms and how it's synergized with our assist solutions to help plan, guide, and assess complex procedures, such as prostate artery embolizations.